Good day and welcome. I'm Tonya Winders, the president of the Global Allergy and Airways Patient Platform, and it's our joy and privilege to host you today on this World COPD Day 2020. November 18th is now recognized as the day in which we as a community come together to recognize the burden and the prevalence of COPD. With over 300 million people living worldwide with this condition, it has a great burden and impact on the day-to-day. And as we know, unfortunately, it's often underscored and not recognized as fully as it should be. And so we're excited that on this World COPD Day 2020, that we have a panel with two of the leading global experts in chronic obstructive pulmonary disease. So today I'm joined by Dr. John Hurst and Dr. Mohit Bhutani, and we are going to be talking about a look at chronic obstructive pulmonary disease, the burden, the prevalence, the treatment, but also introducing to you a very exciting development of the first COPD patient charter document. So welcome, Dr. Hurst and Dr. Bhutani.
Thank you, Tonya. Hello, pleased to be here.
Thanks, Tonya. Yeah, pleased to be here as well.
So first, let's just talk a little bit about what COPD is. COPD is often what we call an umbrella term of chronic obstructive pulmonary disease, and it is a series of progressive lung diseases that are often characterized by difficulty breathing. So what's the difference between emphysema, chronic bronchitis, and COPD, or are they one and the same? Dr. Hurst?
That's a really interesting question, isn't it? And I think it fundamentally depends on which part of the lung has been mostly affected. So if it's the air sacs, the very end bits of the airways that are affected, then that tends to be what emphysema is. If it's the larger airways, the main bronchi, and they're affected, that tends to be chronic bronchitis. And it's the bit in the middle, the bit that connects the large airways with the alveoli, the so-called small airways. When those are affected by the disease process, then that, strictly speaking, is what COPD is.
Okay. And what would you have to add, Dr. Bhutani?
Yeah, when I teach my medical students and my residents about COPD, I kind of use COPD as being the umbrella term, and the two major sort of pathologies that COPD can evolve into, I define as being emphysema and chronic bronchitis. One is emphysema is an anatomical abnormality, like John has alluded to, with the small air sacs being affected by it. Whereas chronic bronchitis is more of a clinical definition where you're having ongoing symptoms that are persistent over a long period of time. But at the end of the day, they both result in a physiological impairment or limitation that is very similar between the two diseases.
Absolutely. Well, and as I said before, there are over 384 million people that are currently suffering from COPD throughout the world. And unfortunately, it is the third leading cause of death globally. Some estimated 3 million people die each year. And we know that COPD actually, as far as diagnosis and treatment and approach, actually varies country to country throughout the world. So what are some of the trends that you've seen in your work and in the countries that each of you represent? Dr. Bhutani, how about you go first?
Okay, for sure. So yeah, it's interesting, for the third leading cause of death and for a disease that in many countries it's the #1 cause for hospitalizations and associated with the longest length of stay. It's quite interesting that the practice of COPD and the implementation of the non-pharmacological and pharmacological strategies is so varied across country, within a country, and around the world. So I've seen, variances in terms of approach to diagnosis. I've seen variances in access to non-pharmacological supports like pulmonary rehabilitation and case managers. And we've also seen access to medications that have been proven to be efficacious to improve quality of life, and now to some extent even thinking about improving survival. That access is varied across country and across around the world.
Yeah.
I would totally support that. So, even within a single country, access to really important, effective interventions can vary a lot. And so actually empowering patients to know what they should expect in their care is really important. But for me, the bottom line is actually here, the non-pharmacological, the non-drug interventions are as, if not more important than the medicine. So quitting smoking if you smoke, or reducing exposures to whatever it is that you're exposed to, vaccination, especially influenza vaccination, and this education and exercise class that together we call pulmonary rehabilitation. It's about getting these basics right this time and every time.
It's so true. I mean, we hear this all the time from patients and patient advocates all across the world that are a part of GAAPP, is that, again, in some countries, pulmonary rehab doesn't even exist. There's no physiotherapist or respiratory therapist to even consider offering these types of services. So it really is not even a consideration. And so having those more consistent understandings of both pharmacological treatments and approaches to COPD, but also non-pharmacological treatments and approaches is really a starting point that I think is helping us to understand what a global standard may be and should include. So we know this disease is very, very costly. Definitely, you know, this is one example just in the United States where we see billions of dollars that are spent each and every year to treat and manage COPD. What about in your own countries? What are the direct cost and indirect cost of COPD?
So the costs here are similarly large. So the prevalence of COPD in the UK is similar to the US. So on a per capita basis, it's similar. And actually, what's driving those costs, importantly, are the acute deteriorations that people with COPD experience from time to time, infections or exacerbations. And what's tragic about that for me, or what's really important about that for me, is that many of these episodes are preventable if we get the treatment right. So yes, there's a huge cost attached to this, but there's also a missed opportunity cost in preventing exacerbations, which are driving a lot of the spend.
Yes, absolutely. Yeah.
Just to add to that, you know, in Canada, we're in the province that I work in particular, we're very, very data rich, and we did a project a few years ago to look at the total costs of care within the province. And the reality of it is, as to John's point, that there's a huge burden of preventable cost here. 50% of the costs of the care for COPD are due to the hospitalizations associated with that care. And so if we can reduce the hospitalization rates by improving the access to non-pharmacological and pharmacological care as an outpatient, you inadvertently save money because you're preventing them from coming to hospital at the end of the day. So I think to John's point, we want to make sure that everything we can be done to keep them out of hospital and living a good quality of life is critical to improving outcomes for the patient, most importantly, but then also reducing the cost of care associated with the disease.
I would agree
Absolutely.
with that. And one other thing that perhaps is sometimes forgotten is the cost to family and friends who are caring for people with COPD, who have to take time off work because they're looking after loved ones, and that's not always captured in these figures. So there's a hidden cost to some of this too.
Absolutely, I was just going to say that. So it's that direct cost that is oftentimes easy to calculate, right? Because we can look at claims data, we can look at system-wide approaches and better understand those direct costs. However, it's those indirect costs that are sometimes so much more challenging. And I think that, again, these are direct costs that are reflected here in the close to 50 billion in 2020 in the US, but what we know is that the indirect cost is at least 2 or 3 times that. And especially when we look at the caregiver burden, which, as you say, is rarely calculated accurately. So what are the most common symptoms of COPD? If there are patients out there that are watching our Facebook Live today and wondering, do I have COPD? How would I know? What are the most common symptoms?
So I would say breathlessness, cough with phlegm typically, and a predisposition to winter chest infections. But notice that breathlessness is going to depend on how active you are. So if you're a super active person, then perhaps you notice that breathlessness a bit earlier in the course of a COPD. But if you're someone who's not quite so active, it may be that you're not noticing those symptoms until the condition is more advanced. So breathlessness that's not the same for you. Something's changed, cough and phlegm, winter chest infections. Those are the alert things for me.
And I think it's I think to add to that point, I think it's those symptoms. We know that cigarette and tobacco exposures are the #1 cause, and I'm yet to find somebody who smokes a cigarette who does not expect to cough more or maybe to feel a more shorter breath with activity. There's an expectation of what smoking will do to you. I think most people would agree to that. The caveat is that a lot of those symptoms are the same symptoms as John has highlighted of COPD. And so oftentimes, I think patients who smoke may be having early signs of this, but they sort of say, well, it's just my cigarette smoking, which may be very true. but at the same time, these are early symptoms of COPD as well. So it's to be mindful of it and to report it to your physician about these experiences that you are having, because it may be a motivating factor for you to stop smoking, and it also may be a way to sort of underline to identify this disease at an earlier stage.
No, it's so true. And, you know, sometimes people think, oh, well, this is just the natural part of getting older, right? Of course, I'm more fatigued. Of course, I'm more short of breath. Or perhaps it's just because I'm out of weight. Or, you know, even surprisingly, some people who've never smoked that have these types of symptoms, right? And so that's one of the misnomers that I think we've tried to correct in our COPD awareness, is that you can get COPD whether you've smoked or not smoked. And certainly you've got a greater predisposition and likelihood if you have a smoking history. But what percentage would you say in your patient population have never smoked?
For my population, yeah. So it's interesting. The demographics are changing over time. I'm seeing, I would say, just to answer your question, probably about 10 to 15% of my patient population is people who have never smoked a significant amount of tobacco. But as you said, there's a number of secondary causes, as you're alluding to in the slide before you right now. Occupational exposures, indoor and outdoor pollution. As we realize the other risk factors for the development of this disease, you know, we're realizing smoking, because the rates are going down in terms of the world prevalence of tobacco smoke, but there are other forms of smoke, e-cigarettes, marijuana smoke. There's other factors that might contribute to the development of this disease that go beyond traditional tobacco smoke.
Yeah.
I would say that's similar to where I work here in London. It's a minority of people who've never smoked. We do have an alpha-1 antitrypsin deficiency service, which provides a genetic model of susceptibility. And so the majority of those patients, in fact, have never smoked. And a lot of the work in terms of research that I do is global. So we work in Uganda, Peru, and Nepal, and in situations there where people have been exposed to biomass smoke, so cooking and heating their homes by burning traditional fuels on stoves. Again, there's a significant proportion of COPD that's not attributable to cigarette smoke in those settings.
Well, and I think that is one of the myths and misperceptions that we've even tried to address, and we'll talk a bit more about that when we get to the charter and the different principles, but that stigma. And sometimes people feel like, well, I brought this on myself because I had a bad habit. But, you know, we don't do that. We don't have that stigma when it comes to things like diabetes or cardiovascular disease, of which diet and exercise is a strong contributing factor, right? So I think that there are ways that we can work collectively as an organization and as a community to really reduce that stigma that's oftentimes directly associated with COPD.
Yeah, just to add to that point, I think, you know, one of the things is that, you know, I think tobacco's, and, you know, one of the most addictive known chemicals we have is nicotine. And so I think one of the things that I try to implore to my patients I see is that, you know, this started off perhaps as a lifestyle choice, but it's becomes very quickly a chemical dependence. And, you know, although there might be some guilt about the initial choice of making that lifestyle choice, but at the end of the day, you know, they've become very dependent upon a chemical reaction here. And then I think that they need to understand that. And I think that goes a long way to help dispelling some of the guilt that it wasn't just necessarily them. And I think that helps a patient understand that.
Yeah, and I was going to add, Tonya, I think if you're seeing or sensing stigma from your clinician, then you need to change your clinician.
Yes.
That's right.
Well, I love that you brought that up, John, because I do think that there is a point that, you know, you have to realize that it is a partnership between the patient and the provider. And if you're not feeling well supported as a whole person, if you are feeling that, you know, sort of reducing the personal burden and guilt and shame piece, then perhaps you don't have the right partner. Yeah. So what about some of the more psychosocial aspects of COPD that are outlined in this slide? What are your thoughts there?
So clearly, work is important for many people's self-esteem, for their financial stability, for feeling their place in the world. And therefore, if symptoms are interfering with work, then that can be a major impact on some people. And the same is true for social activities, right? The things that we enjoy in life, socializing with our friends, playing with our kids, our grandchildren. And when symptoms of COPD, if they are interfering with those kind of activities, it's pretty understandable, I think, actually, that there can be a profound impact on people's health status. And so working how to maximize people's function, how they can still live well with COPD, utterly critical.
Yeah, and what about some of the other psychosocial effects, Dr. Bhutani?
Yeah, I think you've kind of highlighted in there that ideas like the depression and the mental, the psychiatric aspects of this disease are kind of underappreciated. I think estimates range between 30 to 40% of our patients have associated depression, and rightfully so. It's a disease that limits their activity. It causes them to be in hospital for many periods of time, for long periods of time, and so the depression aspect of things is very impactful to disease outcome for our patients. And I think things like pulmonary rehabilitation, time and time, in many different ways of looking at the impact it has on the psychiatric aspects of this disease. We know that pulmonary rehabilitation is profoundly beneficial. So, a low-cost, high-yield intervention for their underlying lung disease is one thing that pulmonary rehab provides, but also creating a sense of the fact that they don't need to live like they are living, and giving them the tools and the education and the exercises that help them live a better quality of life. Those things together, I think we can really have a profoundly strong impact on the psychiatric aspects of this disease.
Yeah, I think we all have had an opportunity to somewhat relate to this, right? Because we've all felt somewhat that social isolation over the last several months of living through the global pandemic. But this is the story, this is the patient journey that we hear day in, day out from so many COPD patients who are saying, I have to stay home. I have to limit my social engagement. I have to reconsider about what are the potential risks of being in a group setting every day of my life, irrespective of the global pandemic. So I think that this slide really does a nice job of bringing home that patient experience that unfortunately is felt by so many. And again, we know that this does result in many more emergency room visits than hospital stays, and those direct and indirect costs that we've talked about before that are so difficult to measure. So let's talk about what brought us to actually developing the COPD patient journey. As we talked about before, this is the first of its kind. There is a existing document as a severe asthma patient charter that has been published, but as far as we could research and see in the literature, really nothing from a patient perspective and from an expert perspective that outlined what the quality of care patients should deserve or should expect. And so we worked together along with a group of other experts in respiratory care to come up with this peer-reviewed publication that is a COPD patient charter, and is actually going to be released today on World COPD Day in Advances in Therapy journal. So tell me a little bit about kind of the purpose of the charter, the way we went about meeting with the work group and working through what mattered most to patients, and then what the purpose is. What do we hope it will accomplish?
I'll leave it to maybe John. He's the lead author on it. So maybe John, go ahead.
So I suppose at its heart, what we wanted to do was to highlight to people what good care looks like, and empower them to ask and to expect it when they meet their clinicians. And that actually sounds pretty basic, doesn't it, when you say it like that? But actually, many patients don't know what good care looks like. And so we started from that principle. I should say that there's an existing document in asthma, another common respiratory condition, and I think the reaction of the asthma community and the patient community to that's been very positive, and that's really driven some change. And so as a group of COPD clinicians, Mohit and myself, and working with you and your organization, Tonya, and other colleagues as well from around the world, we really felt that we could and that we should do something similar. So the methodology was to bring people together in person initially, because we were doing this a little while ago now, but more recently virtually, to talk about what we thought was important, and to come up with some key guiding principles. You'll be showing those, I'm sure, in a second, but more importantly, stress testing them, testing them with each other and with our networks to make sure that they made sense, to make sure that they rang true, that they felt right. And so that was the process that we went through. I guess the other thing to say is that actually many clinicians, and I certainly speak for myself here, many clinicians are not used to the policy change space. So we're used to dealing with individual patients and perhaps within networks locally, but we're not so used actually to writing and to being involved with documents which can lobby funders, lobby governments and commissioners to make overarching changes to services. And it was that as well that I think brought everybody together, because we felt that we could and should do something.
Yes. Well,
Yeah.
and any additional thoughts, Mohit?
No, I was going to say, I think John summarized it quite nicely. I think the big thing was to really put into one document, I call it the North Star of treatment for patients with COPD. This is what we should all aspire to, and that they should aspire to, and that they're not getting the kinds of care that we think are important. I think that they should drive it. Now they got something to hold on to and present to their clinicians or to their policymakers, their health policymakers, or government, to sort of say, hey, listen, like, I'm not getting what I think I deserve to get for my care. And here it is, nicely summarized by a group of world experts, patient advocacy groups, and patients alike to come together and say, this is what we really should be aiming towards. So it was I'm really proud of the work that we've done together here.
Me too. I feel like it is these opportunities where we come together in a multidisciplinary fashion, where we have the leading experts in respiratory care, but we also have allied health professionals and respiratory therapists and other professional societies, in addition to the patient voice and the patient advocacy voice coming around the table, and in industry support as well, to say, this isn't about getting our treatment in the hands of patients. This is about changing the mindset of what that standard of care looks like, and changing the expectation, regardless of where a patient lives, about what they should expect from that interaction between themselves, their provider, and their health insurer, whether that's the government or a private commercial type of plan. And so without further ado, let's go into the charter principles. And I think that this really speaks to the need. Definitely, we realize that COPD has not sort of garnered the respect or the attention or the funding that it deserved. We recognize that healthcare systems don't adequately really equip providers or patients to demand that care, that level of care, and expect that level of care. And that ultimately drives both the exacerbation rates that we've talked about and the cost that are associated with those, but also the mortality rates. And we believe that this foundational document of the charter actually provides, if you will, a new approach, a new standard, a new expectation within the community that will fundamentally change some of these burden and prevalence numbers. So the first one, I deserve timely access for the diagnosis and assessment of my COPD. What do you think are some of the challenges to that, or what do you traditionally hear from patients are the length of time before they actually get that appropriate diagnosis today? Mohit, why don't you go first?
Sure. Yeah. No. Absolutely. So, I think this is a bit of a complicated topic because, at the end of the day, we know there's a physiological test, spirometry, which makes the diagnosis of COPD. But ultimately, it's case recognition and kind of some of the things we talked about earlier. Physicians and patients thinking about, what are these risk factors, what are these symptoms, and when should I talk to my physician about getting the diagnosis. We know, or going for spirometry, we know the disease is really not diagnosed until it's in a moderate or more severe stage. I mean, the data is very clear upon that. But what could we do for these patients if we diagnose it at a milder stage, or if before the disease even developed at all with smoking cessation principles? So I think the key here is that if you've got a risk factor, for patients to recognize that and have a discussion with their family doctors or their primary care physicians regarding when and what if they should go for that testing and try to diagnose this disease at an earlier stage.
Yeah.
So spirometry is a diagnostic test, and it's not expensive, but there are parts of the world where it's simply not available, and yes, having the equipment is not the same as being able to do the test properly and being able to interpret the test. But I think what's important for me here is the identification of people who are at risk of COPD through the symptoms that we were talking about earlier on, Tonya, all those risks of winter chest infections, because there are other tools that people can use even in the absence of spirometry. So I'm thinking about simple questionnaires together with more simple measures of lung peak flow that can help to decide whether or not spirometry might be necessary if the spirometry itself is a scarce resource. So there's really no excuse actually for not taking a more proactive view wherever you are, because those kind of tools can be implemented readily, even where spirometry is scarce.
Right. Now, the second principle says, I deserve to understand what having COPD means for me and how the disease may progress. And so, oftentimes we hear from patients and they say, I got that diagnosis and I felt that it was a death sentence, that it meant that for certain I was going to die from COPD. Is that the case? Should that be the expectation, or does this aspire to something better?
Oh, we have to aspire to something better than that. I think if you are given a diagnosis of diabetes, say here in the UK, then what you would expect to receive is a tailored education program about diabetes, about how to look after your diabetes, about how to measure your blood sugar level, which is important in diabetes. And that doesn't exist in some other diseases, and COPD would be a good example of that. I hope we can change that through this charter. But why would you not talk to people about the condition that they're living with? Why would you not support them to become an expert in their own condition? All that can come out of that is that they're going to learn how to manage their condition in partnership with their clinicians in a better way. It's crazy not to. How are we not doing that, Tonya?
Yes, it really is.
I was just going to say that. I mean, empowering the patient with COPD management is critical. We've had study over study to look at the role of self-management when used in the appropriate setting with a case manager and appropriate tools for COPD. Getting the patient involved in their management reduces cost of care, improves outcomes, and we've got plenty of evidence to sort of suggest that. And every guideline, whether it's GOLD or your national guideline, recognizes that. We just need to translate that into actual practice, which is something that's really missing for the third leading cause of death worldwide.
Absolutely. Now, the third principle, I deserve access to the best available evidence-based personalized treatment to ensure I can live as well and as long as possible. And I think, Dr. Bhutani, you touched on this, right, with the GOLD guidelines. We do have a global guideline and standard. And so how do we make this principle come to life?
Yeah, I think that's been sort of the challenge that we've had, and we spoke to about it earlier, is that, I think the approach to the non-pharmacological and pharmacological therapy needs to be translated from the GOLD recommendations down to actual boots on the ground practice. We know there's good interventions on both sides of the coin, pharmacological, non-pharmacological, but they need to be done in concert with each other. And the data would say that the two work best when they work together. So, I think that's a challenge that's before us. And I think, the charter is saying that these recommendations exist. We need to put them into practice, and we need to make sure that every patient has a chance to experience that to give them the best outcomes. I struggle with this fact because, pulmonary rehabilitation, to John's earlier point, is probably as important as any inhaled therapy you can probably take for patients with COPD. Yet in Canada, a recent audit that we did a few years ago, only 1% to 2% of patients with COPD have access to this. And so could you imagine people with heart disease or who had a heart attack, only 2% of them having access to cardiac rehab? I mean, it just doesn't exist, and we know that those numbers have to change. So the recommendation in the charter is to sort of say, well, if it's not available, we got to somehow make it available.
Right. We need to find the way to make that case, and certainly to support, especially those evidence-based approaches that we know make such a big difference. Now, the fourth principle turns toward the urgent review of the management plan, especially once an exacerbation occurs. So when I experience an exacerbation, to prevent further exacerbations and disease progression, that urgent review of the current management plan, does that happen routinely?
Well, it should, but it doesn't. And this is so important. And at one level, I understand why. If someone is coming to see you as a clinician because they have an exacerbation, because they have a chest infection, then the focus of that consultation is getting that person better, is assessing them, prescribing the additional treatment they might need, antibiotics, for example, and making sure that they're on the road to recovery. But people stop there, and they shouldn't, they mustn't. Because if someone's had an exacerbation, then something's gone wrong in their exacerbation preventative care, perhaps. Perhaps exacerbations will happen from time to time, but if we're not using an exacerbation event as an opportunity to question, have we done absolutely everything we can for you to reduce the risk of future exacerbations, then we are not managing that exacerbation properly. It may not be the right time to do it actually at the time that someone's sick. That might mean bringing them back when they've recovered to have that consultation, but it must be seen as an opportunity to optimize preventative care. We're missing a trick otherwise.
Absolutely. And I think that that is the disconnect, that so many times patients walk out of the hospital or walk out on the heels of that exacerbation, and really they're lost in the system. And so we're not following up in a very timely way. Now, we do know that there are readmission penalties and negative incentives and things like that to prevent the readmission of patients. And yet that still is not taking that proactive approach that I think this principle really fundamentally is rooted in. Now, the fifth principle is I deserve access to specialist care when needed, whether provided in the hospital or in the community, to manage my COPD, irrespective of where I live. So we know that access to specialty care is very challenging, especially in different regions of the world. But even in more developed countries, we oftentimes hear from patients that it's taken years to get to the appropriate specialist. So tell us a little bit about different approaches to ensure that this principle is actually followed.
So I think, if anything that we've learned from the COVID pandemic is the role of virtual healthcare. In the province where I live in, we've been using telehealth for a number of years to meet with patients who live in more rural environments. We live in a winter country, so traveling on the winter roads in Canada sometimes is not the easiest when you got to drive, 200 or 300 miles to get to see us. So telehealth has been sort of an infrastructure that we've had here for a long time, but it's telehealth on steroids now with COVID because nobody really wants to come in to see you and stay home and try to follow public health recommendations. So, I think right now with the role of telehealth, I think right now there really is no reason why a patient should not have a consultation with a specialist based on location. I think governments and health policymakers need to respond to the remuneration that goes along with it to make sure that it's cost effective for those types of consults to happen. But these things are critical, and having ongoing contact with your specialist or your primary care physician is critical. And no matter where you live now with telehealth and technology, I think we're able to bridge a lot of those gaps. So that's, yes, in Alberta where I live, telehealth has been, as I say, has been used for a number of years.
I definitely believe that that's one of the silver linings of this COVID cloud, that we have seen that rapid adoption. Dr. Hurst?
I was just going to add that we've been careful with the words here, and that says specialist, not physician. And actually the wider healthcare team, so that might be specialist nurses, physiotherapists, pharmacists, smoking cessation counselors, dietitians, psychologists, and a whole lot of other people too. There's a huge amount of staff resource out there with expertise in managing COPD. So specialists, yes, but don't confuse specialist with physician necessarily.
Yes, that's such a great point. I really appreciate that you bring that forward, because it is about that multidisciplinary team approach and knowing what even resources may be available and should be accessed, right? So then principle 6 is I deserve to live with COPD freely while maximizing quality of life without stigma or guilt. So this is the one that we were talking about before, and kind of what the overarching theme that sometimes we hear from patients of, I brought this on myself, or, this is because I made bad choices. And yet it's really important for overall quality of life and for mental health and well-being that you not internalize that disease and not blame yourself, if you will. So speak to me about this principle and what we ultimately hope to gain in the conversation of the charter.
So I've been working in respiratory medicine now for about 20 years, and I'm hugely proud to be a respiratory clinician and part of a multi-professional respiratory team, because the one thing that I think that we do is respect people and treat them irrespective of the background that they come from, in whatever way that means, smoking or occupation or whatever part of the world that they've come from. And I really do mean, if you're seeing a stigma and stigmatizing behavior from your clinicians, then you need to think about finding a different clinician. That is not what you should expect, and it's not what we aspire to deliver. This is fundamental.
Yes.
Yeah, I would certainly echo exactly what John has to say, and I think it's interesting, and then we keep on coming back to pulmonary rehabilitation, but I can't emphasize this enough. When I send patients to our rehab program, the one thing that comes back to me time and time again is that I never realized there were so many other people that live the way that I live, that have the same disease that I have, and that patient support, that recognition that you're not alone in this battle against this illness is really empowering to them, and I think it's motivational, and I think it actually adds to some of the better mental health outcomes that are associated with pulmonary rehabilitation, is that you're not in this by yourself, and there are other people that do have the same limitations that you might have, but you can overcome those, and teaching and empowering your patients to accomplish those goals, I think, is really critical to all of this. So I 100% agree with what John said there.
The other thing in relation to that actually is the relationship between the measured severity of lung function impairment and quality of life. And actually the relationship there is very weak. We can see people who've got more severe COPD as measured by lung function, whose quality of life is actually rather good. They're getting on, they're living life to the full, to the maximum, despite their lung function impairment. And conversely, sometimes people who have less severe lung function impairment, whose quality of life impairment is greater, and that does suggest that this is something that's changeable. And I agree with Mohit, pulmonary rehabilitation, this exercise and education class, really, really important intervention for doing that.
And I think it does come down to empowerment. I love that you use that word, because I do believe that, again, our aim and our goal of the COPD Patient Charter was to drive awareness of the current unmet need and the burden, but also to highlight to governments, to healthcare providers, to policymakers, to the lung health industry, and to patients and caregivers that care can change. It should change, that we should have a different expectation. And that starts with that individual patient empowerment and really working together to deliver meaningful improvements in care, both today and moving forward. So I'm excited about how this charter will be used and how it will ignite conversations with patients and their providers, with patients and their families, and also at the government level, at that payer policymaker level. I think it is a fundamental foundational document that I know I'm very proud to have been a part of, and certainly proud to co-author with you both. And I want to thank you again for your time today, for joining us on this World COPD Day 2020. I believe that we all stand together, united in this fact that COPD patients truly do have the right to quality guidelines-based healthcare that's delivered in a timely, collaborative way, and that this charter will go a long way to advancing that. So happy World COPD Day. Thank you both for joining us today. We'll look forward to the ongoing conversation.
Pleasure. Thank you.
Thank you.
Okay, so that's it.
That was great.
Thank you.
You're very good at that, Tonya. Holy smokes.